Hello, I'm Dr. Lynda Young, and you're watching Health Matters, a production of the Worcester District Medical Society in collaboration with WCCA TV. Thank you for joining us. We have a really interesting guest with us today, and I'm very excited about this. With me today is Dr. Loris Fichera. He's an assistant professor of robotics at Worcester Polytechnic Institute, and I'm sorry, it's Fichera.
That's fine.
Sorry.
That's okay.
Anyhow, his research centers around medical robotics, computer-assisted surgery, and image-guided surgery. So overall, Professor Fichera looks at the application of robotics and computer science to enhance medical procedures. This is such an exciting field, and I know robotics has been around for a while, but the precision that Dr. Fichera and his colleagues are working on at WPI is absolutely fascinating. And when I had heard about it, I thought this would make something really interesting for our viewers to see. So I'm going to welcome you. Thank you for coming and joining us.
Thank you for having me.
So I'm going to just ask you, I remember robotics being very exciting because a physician can be in another room, in another city, in another country.
Right.
And can control surgery going on really far away. And I thought, wow, that's incredible. And they can use tiny little instruments, and they don't have to have their big fingers in the way. And it was such a terrific field to open up. So I was really excited to hear all the work that's going on at WPI. So can you tell me a little bit more about this work?
Absolutely. First of all, I think you did a very good description of what the exciting things about surgical robotics are. I remember in the early days, the Lindbergh experiment, you may have heard of, which was that cross-Atlantic surgery. There was one physician in Europe performing surgery on one patient in the United States, and everybody marveled. I think it was the early 2000s maybe. Now, I give or take, I may be not exactly I may not remember this correctly, like to the specific here. But yes, there was a lot of excitement early on. And then the other things are, of course, precision. We all think about all the time. Physicians are really good with surgeons are really good with their hands, but even the best surgeons are always going to have a little bit of hand tremor. Mm-hmm. And of course, robotics takes that away.
Yes.
And then finally, the other thing that you said was access, making surgical instruments really small. That's the other, and going to places into the human body where it would be impossible to go otherwise. That's also a big deal for robotic surgery. I work at WPI. We have a cluster of faculty there. I'm not the only one. I'm one of the group of surgical robotics faculty, and we work in different areas of surgical robotics. And these days, really, what we are trying to do at WPI is to build the next generation of surgical robots. We already have surgical robots in operating rooms worldwide. In fact, I believe Intuitive Surgical, which is one of the major surgical robotics company on the market, I think they announced recently that they had recently performed their 10 million procedure.
Oh my, wow.
I believe this was like late 2021, so it's relatively recent. So we have surgical robotics technology in the operating room helping physicians today. Mm-hmm. What we are trying to do is to push things one notch ahead, push things a little bit more, and really ask ourselves, what can we do with robotics that we haven't explored until now? And really, the answer is that if we look at surgical robots in operating rooms these days, they are primarily instruments that replicate the movements of a physician. Mm-hmm. What we are trying to do is we are trying to build surgical robots that are not only doing that, but also taking over, for instance, when something goes wrong in a procedure, so they can detect if something is about to go wrong, and they do that with very advanced sensing, very detailed imaging, for instance, being able to see into the tissue and figure out if something wrong is about to happen.
So what kind of imaging are you talking about?
So all sorts of medical imaging and more. The traditional medical imaging methods we are all familiar with include, of course, CAT scans, MRI. Actually, here at WPI, we have this facility where we have a fully clinical MRI that we use to develop robots that can perform procedures under the guidance of the MRI images. So the robot can see into the patient using the MRI, and then the robot knows where to go. The analogy I frequently use is that of GPS for surgical robots.
Yes,
of course, whenever we drive, we need to know where we're going, and we use the GPS on our phone. And this GPS is normally based on images of a city. It's in very much the same way an MRI or any other imaging modality can tell us where things are inside the body and can inform a robot on where to go, and sometimes also, not least important, what to avoid.
Yes, that's true too.
Right.
So this is where my mind just wandered. So MRI is magnetic resonance imaging, and I do know that you can't have anything metal nearby. So what are these robots made of?
Oh, that's a great question. And that's exactly right. You cannot have metal, but you can have many other things. And so, for instance, you can have plastics.
Yeah.
So many of the robots we're building are made of plastics. You can have different types of rubber, and so we use a lot of that as well. And you can have some metals. It's important to avoid the metals that are ferromagnetic, so the metals that are attracted by magnets, because of course they pose a danger inside an MRI. They can, they become projectiles. But there are some metals that are non-ferromagnetic, and a type of metal I personally use to build my robots, for instance, is nickel titanium. So it's this metal alloy that's made 50% of nickel and 50% of titanium. It's actually very much used in cardiac stents.
Oh, okay, yeah.
Yep, and so it's non-ferromagnetic, it's biocompatible, that's why they use it in cardiac stents, and so it's a perfect material, and it is, so it can work well inside an MRI. And so one of the things I personally do, for instance, is I build these robotic arms made of very tiny nickel titanium tubes that act as sort of, tentacles that can go into the body and do surgery on very remote places.
Oh my goodness. And it's least invasive. Do you need smaller incisions or cuts to get to the areas, or is that a possibility? I'm just thinking about how this works.
Absolutely. The instruments of the Da Vinci robot, so that's our standard of minimally invasive surgery these days. They are typically 8 millimeter in diameter. So when we think about surgical instruments deployed,
That is tiny.
That is tiny.
That is tiny.
The kind of robots I am building with my colleagues at WPI are much smaller than that. So we are talking about maybe 1 millimeter or smaller.
Wow.
So really the vision is maybe today you do surgery, you receive surgery, and you need a few stitches to close these very tiny incisions.
Yes.
Maybe in the future, these incisions are going to be so small, you're not going to need stitches even.
Wow.
Maybe it's just like a Band-Aid and you go home.
My goodness. So you had mentioned your colleagues. So who do you collaborate with?
So robotics is a highly interdisciplinary field. So I collaborate with lots of people, mechanical engineers, computer scientists, electrical engineers. Here at WPI, I have two good colleagues, Greg Fisher and Kai Tang. They are both roboticists like me. And so on the technical side, these are really, all important collaborations, because sometimes there is something I need to do and, I may not have the right expertise for the task. It's useful to have someone who is a mechanical engineer to talk to. And that's, I believe, also the beauty of being in a place that's highly interdisciplinary like WPI. However, there is one thing that I should mention, and it's probably the most important collaborations that I have, and those are collaborations with medical doctors. Because without them, and when I say we, I mean we engineers, we wouldn't be able to do what we are doing.
Well, you know the logistics of this, they know the anatomy, I guess. Is that kind of where that collaboration comes in?
Yes, and I would say it actually goes beyond that. Before coming to WPI, I worked at Vanderbilt University in Nashville, Tennessee. For 2 years, I was a researcher there. And even though I was an engineer, my desk and laboratory was within the medical center. And I used to work with a doctor full time. And those 2 years were really influential in my career because I realized how much I didn't know about medicine and how much I didn't know about surgery. And also that if I really wanted to make an impact in medicine, I had to work with a doctor. There is some, I mean, I'm not a doctor. I don't know what disease states are challenging to treat. I really have no idea sometimes what the clinical challenges they are facing are. So anytime I start working on a new project, my team and I, we always ask ourselves, what is the clinical challenge that we are trying to solve? And frequently that question does not have a simple answer. So what we have to do is to go to the hospital or go to the clinic, spend many hours, watch procedures, interview physicians, and really try to learn as much as possible from them. We really become students, medical students ourselves.
It sounds it, yes. So where does all this take place? Do you actually have hospital or surgical suites set up at WPI?
Have you ever seen that building that you can see from
I live right near WPI.
Okay, there you go. So you have seen that building.
Yes.
I'm sure many people have seen it from driving on the highway on I-290. So it's in the gateway, our gateway campus. And so over there we have all of our laboratories where we actually build the robots. But then we also have, inside our own building, we have a replica of clinical environments. So we have a mock operating room, a mock imaging suite, a mock ICU. And the idea really is that if we are building medical devices, if we're building surgical robots, we need to be able to test them in the environment where they are going to be deployed. That's one thing. The other one is, having worked in the past in places that don't have such a facility, it's always challenging to test robots, surgical robots, because that typically involves making arrangements with the hospital and then going there. But of course, hospitals, their facilities during the day, they are treating patients, they are seeing people, they are doing real procedures. Most of the times you end up working at night. Then maybe something breaks because we are building prototypes. What do you do at that point? Well, you have to pack up everything, load the van, go back to the lab. And instead, having this environment right next to you, it's so much more convenient and it really accelerates the development.
So you had mentioned something called Practice Point?
That's right.
So what's that?
That is exactly the facility I was describing. So that's this center that's part of WPI where we have all these mock suites where we can test all of our medical devices.
Okay. So that sounds exciting too, just seeing that. My goodness. So you have a model here. Can you explain what this is and what you in particular, I think that's your expertise, is that particular area?
That is exactly right.
So tell us about that.
So it's an anatomical model of the upper airway, and particularly the region I would like to focus on with you today is the voice box, because most of my research specifically look at new robots to treat disease in the voice box. And so I brought this model here because I want to illustrate the challenge of performing procedures in this area. So this is a model of the upper airway tongue. I'm going to remove this. This is nice. This is one of those models that sell for like medical students so that they can learn the anatomy. As I said, we are medical students at the end of the day.
That's right. So you just took the tongue off. Okay.
Right. And so what's left is the larynx, so where the voice box is located. Now,
vocal cords.
Right, the vocal cords. Now this is also nice because you can open this so you can see what's inside. So the area we are focused on specifically is this one around here. So this little structure here, these are the vocal cords. And unfortunately, this is an area where tumors may grow. The statistics we have say that about 1 in 40 adults at any time have a lesion. By lesion, we mean a growth on the vocal folds. And this growth may be benign, sometimes may be malignant and needs to be, either way, it needs to be treated. If it's benign, it's still something that ideally needs to be removed because it can affect the voice. And it may make people unable to speak. If it's malignant, of course, you want to take it away because it can spread to other places. And so the challenge here is twofold. The first one is getting here. It's not
so
as simple.
You're looking at like right in through here on a real person. So
Right. And so I'm currently collaborating with a physician in Boston at Brigham and Women's who treat some of these tumors, especially the benign ones, using endoscopy in an office setting in the clinic. The old approach of, the established approach to treat all these tumors is to cut them away in the operating room. But physicians have been exploring in recent years the possibility of just like treating them with lasers in an office setting. So the idea is that the patient would just go for an office visit, receive the procedure, which typically lasts 5 to 10 minutes, and then they just walk away and go home, which is so much better than, having to undergo general anesthesia and, all the things that come with it. So they use an endoscope to get inside here, and that solves part of the problem. Yes?
So describe an endoscope.
An endoscope is a device which has the form of a tube. It's flexible, and it has a little tiny digital camera at the tip. So the idea is that the physician uses it to get into the body without actually having to create openings, without actually having to do incisions.
Right. They just go through the mouth.
In this specific case, they go through the nose.
Nose, yes, right.
And I know it may sound eerie a little bit, but it's actually sometimes, this is once again what I hear from my collaborators. Going through the nose is actually better because it doesn't trigger the gag reflex as badly as going through the mouth.
I was just thinking you can kind of bypass that.
Right.
So I'm thinking the camera that's on there must project onto a screen somewhere.
There is a screen outside. That's right. And so the physician can now see what's inside the voice box on a screen without actually having to cut the throat open.
Right.
So this solves part of the challenge, right? Getting there. The other challenge is that the anatomy can be quite complex. So you have a lot of cavities inside here, and sometimes these tumors grow into these cavities, and it's difficult to reach those places. And that's where we, with my team, come in, because we give physicians these very tiny tentacle robots that can go in and reach very hard to reach places.
Gosh.
And the other thing that's important here, and that's the other main challenge, is the accuracy, of course. To give everybody an idea, the vocal folds in human adults are typically 1.2 to 1.5 centimeters in length.
Okay.
I'm trying to think in inches. That's probably like roughly half an inch.
Yeah, about a half an inch. Yes.
So that's the entire organ, and typically the growth that has to be removed is much smaller.
Yeah.
So ideally, that gives us an idea of how much precision is required. And once again, that's where robotics can really lend physicians a hand, because otherwise it will be very difficult for them to accurately target the tumor they're trying to
something
treat.
that small. And I would imagine in the old days, I guess I'd say, in the old days, those lesions would grow to the point where they would probably be very difficult or disfiguring to remove.
Yes, they were.
But this can get detected a lot sooner?
It does. The old approach, I've never seen it, but the old approach, what I read in medical handbooks, was to actually do something really gruesome, which was to essentially take away the entire voice box. These were the old days, and I mean, like, the idea was, oh, we have something that's growing inside there, we don't know what it is, let's just be sure and remove the entire thing.
Yeah.
And can you imagine, like, life after that?
Right.
This is exciting to me because this really gives us an option to go there before things go too bad and restore someone's voice.
Yes, that's fascinating. And I know your colleagues do other parts of the body, but this is particularly interesting just because of the technology and the small space that you have to work with. And it's an airway. You got to breathe.
Yeah. I believe that many of the challenges that I have on this specific project are actually challenges. I mean, this project is really representative of many other projects in other parts of the body. The challenges we have here are, I would say, the same challenges we find in other places. So having to work in a very confined cavity, also having to be really accurate, and so on.
Right. Wow, that's so interesting. And what an advancement for medicine. My goodness. So put your future hat on. Where do you see this going?
I'm really excited, honestly. I mean, I'm biased, of course, because I'm a roboticist. I'm a robotics engineer. But personally, I am really excited by the idea of robots becoming increasingly advanced in their capabilities, up to the point of not just being tools in the hand of a physician, but instead robots being really collaborators of a physician. And through the combination of human abilities, human knowledge, medical expertise, and dexterity, sensing, and precision of robots being able to do procedures that right now are impossible. Personally, I like many of my projects involve using lasers. And when lasers were first invented, one of the initial ideas was to use them to perform surgery on a single cell, because for the first time we were able to actually focus some tool on a scale that's comparable to that of a single cell. We actually never...
And that's really tiny.
That's super tiny. Yeah, and we never got there clinically. I mean, there have been benchtop proof of concepts, but we actually never got to the point of having a clinical technology that enables us to do surgery on a single cell. But I'm thinking about the future where maybe with advances in sensing and medical imaging, we're going to be able to detect the onset of certain diseases, and I think about cancer specifically, much earlier than we are today. We can detect immediately if individual cells are going rogue. And then with the precision of robotics, we can go in and remove those cells immediately. Right. And essentially, this would enable us to intervene much earlier than we can today, before tumors grow and become a problem.
Right. So how would how would somebody diagnose that? So I have somebody that I think has something wrong with them, and I'll use vocal cords as an example. Let's say they just say, oh, it's because I scream too much, or because whatever, that's why my voice is hoarse, or that's why my voice is funny now. How do you first initially think that you need to use these procedures?
So I should probably say, first of all, I'm not a medical doctor, so whatever I say is, don't take this as medical advice. But yeah, lots of people who end up requiring vocal fold surgery discovered that, first of all, by noticing changes in their voice. And the typical sign frequently is hoarseness of the voice. And then they go for a visit with a specialist, and the specialist decides to have a look inside, and they find out there is something wrong.
Yes. Well, you're not going to believe this, but we're almost to the end of our discussion. So I need you to tell me whatever you would like to say in the next minute or so, maybe not even, as far as what maybe we didn't get to discuss that you wanted to mention.
Sure. If there is one thought I would like to share with you, is that there is a lot of concern these days about robots replacing humans.
I was going to say the science fiction aspect of robots taking over, and that's not where we're going with this.
I personally don't, and this is my personal vision, and I personally don't think that's going to happen. I don't think robots are going to replace physicians, and I don't think that's going to happen in the foreseeable future. I just believe that, physicians, we all know, they are among the most trained individuals in our society. They go through many, many years of school for a reason. And what I envision instead is a future where we use robots to really augment the capabilities of a physician, give them the ability to see things that otherwise they wouldn't be able to see, give them the ability to operate at a scale that otherwise would be impossible to operate at, and in that way advance medical science.
It's just incredibly exciting. So this has been terrific. I've learned a lot, and I know that this is an area that is right here in Worcester, which I think is wonderful, and the collaboration that goes on between the scientists and engineers at WPI and the physicians and the students too at UMass Chan Medical School.
It's a very exciting place to be.
It is very exciting. Well, I want to thank you so much for joining us. This is so interesting, and I think we need to collaborate further on this, because it sounds like there's a lot here that we don't even know about. So I'm so glad we were able to have you join us. So thank you again very much.